And now your host for the afternoon, Dr. Jamil Ahmad.
All right, thanks, Blaine. We appreciate Sientra again for helping us host these vital webinars. And today we have a great program lined up, preparing for a return to practice. And we have two key topics. One is leadership in times of crisis. And then the second is going to be discussion about how potentially we may return to providing aesthetic services after this crisis. Blaine, let's get the next slide. Our disclaimer, as usual, is we're given ideas, not legal advice, and all the information that's presented is accurate as of the time of this webinar. Next slide. And some housekeeping items from Blaine.
Yeah, so everybody, hopefully everyone's been on at least one of these webinars before. I'm sure you've all been on Zoom before at this point. My computer and my brain are about to melt from being on Zoom too much. But having said that, in order to run an effective program with so many people on, we currently have over 200 and more piling into the waiting room that I'm admitting as we speak. So please use your Zoom buttons to keep your phone line on mute. Thank you for the illustration of why that's important. I just muted you. Please mute yourself and keep your video off so we can run an effective program. And also, we wanted to show that there's been a lot of these webinars. We've reviewed a lot of important topics, including the CARE Act and the SBA loans and telehealth. And all of these resources that we've done before are posted to the surgery.org or the Aesthetic Society website, and there's a banner that's purple, the COVID-19 banner for resources, and that's where you can find that information. So all of that is housed there, and I hope you find it useful as you guys make plans to manage your practice during this tough time. With that, I will give it back to Dr. Ahmad.
All right, well, we want to also thank Nirav Patel for his performance on the cello to open up the webinar. You're already familiar with who I am. We're very fortunate today to have Jeff Nugent, the Chairman and Chief Executive Officer of Sientra, who's going to talk to us about leadership in times of crisis. Let's get the next slide. And then we're going to segue into defining the aesthetic experience in the new normal. We have Bill Adams, and then also Louis Rios, who's the president-elect of ASERF. And we have Joe Gathe also, who did a nice interview with Bill and Louis, and he's an infectious disease specialist in Houston, Texas, who's been involved in a task force that are consulting with the Texas Medical Board about how we may be able to return to elective surgery, at least in the state of Texas. Let's get the next slide. So before we give Jeff the commands here, we're very fortunate to have Jeff. He's very well known in the aesthetic space, has tremendous experience in the space with leadership. He's been in the space for several decades. His educational background, he has an MBA in marketing and finance. He also has significant military experience, which has given him a lot of insight into organizational aspects and also crisis management. And we're very fortunate to have Jeff, who's been the CEO of Sientra for the past 5 years. Yeah, I think this will be really insightful and helpful to a lot of us as plastic surgeons who are leaders within our own practices. Thanks for being on, Jeff.
No, I appreciate it. And I appreciate the opportunity to share some of the experiences that I've had that really cross the crisis spectrum nothing to compare to what we're dealing with right now, but I don't want to make this a Harvard Business Review compilation of generalities, but these are the things that I've found have made recovery from crises the most effective. And at the end of the day, it really boils down to how do the best leaders inspire the action to recover from whatever those biggest challenges are. And what it really boils down to is that I've found that in the examples that I've experienced, there are people who either ride the recovery or drive the recovery. A couple of examples that I wanted to bring into this that aren't exactly the same, of course, nothing's exactly the same with what we're dealing with, is in the first case, when I started with Johnson & Johnson, I was involved in a task force dealing with the Tylenol crisis. And I'm sure that many of you remember that in the early mid-'80s, there was a case where Tylenol was poisoned with potassium cyanide, and it was limited primarily to the Chicago region, and it shook the corporation, to its foundation. And I learned from our chairman at the time, Jim Burke, who demonstrated the qualities and the factors that allowed the company, as well as the patient population and the consumers, to recover from their lack of trust and confidence in that brand. And in that process, it really, was expedited over a very short period of time. And after all Tylenol was withdrawn from all retail shelves in the country, within 9 months, we were back on the market. We had tamper-proof packaging, and that Tylenol regained its position as the #1 doctor-recommended pain reliever in the country. So that's one that has driven my conclusions. The second one, and I know that we were all involved in 9/11. My perspective was a little bit closer, and I'm not going to deal with the existential issue of 9/11, but I was CEO of Revlon at the time, and we were on Madison and 59th Street in New York, in a 17-story building. And once the word got out, there was an incredible level of panic. And one of the things that stood out in terms of what it took to recover the individuals that were involved was an ability to instill calm, to partition the emotions, the fear that went into this. And that was one of the strongest elements that we used, to be able to restore calm, confidence, et cetera, in being able to recover from that, at least on a local basis, on a relatively short-term, time frame. The 4 key lessons that that I've translated into all these experiences are essentially these, that effective leaders who speed recovery through a crisis insist on remaining calm and inspire everybody else to stay calm, keep their emotions in check. That, like with anything, dealing with a crisis helps if you break it into stages. And we're dealing with one right now, and we're in an early stage of trying to understand what levels of uncertainty there are. What do we do in terms of a condition of pause or hibernation? What is the next stage that you need to undertake to plan for the recovery? And again, it gets back to the difference between riding that recovery and driving it. The third part that made such a difference in everything that frankly I've been involved in is the essential 360-degree blunt communication And when it comes to communication, I've always used the rule that I try to listen 3 times more than I try to talk. But listening to all of the stakeholders, your employees, your patients, your colleagues, et cetera, to be able to keep them advised. Uncertainty and not knowing what's going on, just makes things worse. The last point I want to talk about is a concept that, we use in virtually every organization, and that is a form of governance. And I call them sanity boards. And in, my getting to know, a lot of your practices out there, there are some that are doing this extremely well. And it's less an issue of a disciplined approach than it is a willingness to accept other opinions to help form your definition of reality. So those are the 4 basic skills that I found actually make a difference. And just going through each of them crisply, I think that it gives you an opportunity to redefine your practice right now. That it is it's difficult to do on a normal operating level when you're in full forward motion. You just don't have the time to sit back and benchmark how your practice compares to others nationally and in your region. I think it also allows itself to benefit from, the forum with your employees, listening to them, involving them in what you're putting together. It also gives you an opportunity to, better than anybody else, how your staff, how the people involved in your practice can be improved. And that all leads to creating a plan for your practice, because that's going to make the difference in terms of how you're going to be able to drive this recovery. The next set really boils down to this sanity board that I call to help you adapt to the new normal, because it's not going to be the same. It is not going to be a binary switch that comes on. It's going to be a process, and having the smartest people around you. And that's what I've learned. I've always tried to do that. The most effective leaders I've worked with do that. And it allows you to have your people challenge your opinions and your plans and be involved in a sense of ownership in terms of how you are going to go forward. So, in essence, my advice would be to develop and curate a sanity board of reality as quickly as you possibly can, to help define what new normal is going to look like, and involving the people with as diverse a set of perspectives as you can. And I think the last part boils down to measurement. And again, I've seen a number of practices that do this very well, but I've seen others that don't. And part of this is having a crisp dashboard of what are the most important things that you want to measure. They include financial metrics, they include patient satisfaction, outcomes, recording and so forth. That those are the basis for telling how fast you are improving. And it gives you an opportunity to reward performance, because everyone improves based on incentives and motivation. And an obvious point here is that by rewarding performance, and one of the things I've learned too in business is recognition is more important than compensation. I know you may find that a little bit difficult to accept, but honestly, people are motivated by just being recognized for what they accomplish. So it's not one versus the other, but it really does enhance performance. So the bottom line advice here is to develop a set of practice metrics and manage your business accordingly. And I guess the conclusion here is being competitive today, goes without saying, is very different from what it was 3 months ago. And you need to ask yourself, how can you recover from this crisis that we're dealing with right now? And I guess the real challenge, and this is an example of inspiring each other, inspiring your people, that are they satisfied with riding this recovery, or what is it going to take to truly drive it and be bold and improve the position of your practice as we get to the other side? Those are the primary thoughts that I wanted to share with you. And while they may be a tad general, they come from the heart of a few decades of experience of seeing incredibly successful leaders drive change and overcome significant crises.
Great, thanks so much for that, Jeff. That was very good summary of critical points. So, you know, you brought up this concept of a sanity board, and it may just be semantics, right? But essentially it's a group of people that you can use to help you with decision making, drive direction. Now, what would be your suggestion for the plastic surgeon with the smaller practice, so single surgeon, maybe 5 or 6 employees, versus the plastic surgeons with bigger practices, maybe multiple surgeons, 30, 40 employees? How would each of those surgeons in those circumstances go about trying to develop having a board to help advise them?
Well, it obviously,
who would you include? You know, how often would you meet?
It obviously varies, you know, by the maturity of the practice. But I would always include, you know, the key members of the team involved in the practice, and having them at the table, you know, to be able to express their ideas, because it has multiple benefits. It helps alleviate some of the concerns, some of the fears, some of the emotion. But many times you've got great ideas, you know, coming out of this. I've seen a number of practices involving, you know, practice managers, spouses are, you know, regularly involved in this, as well as colleagues outside, both inside and outside of your practice. Because again, I think, you know, one of the primary benefits of a governance structure is to get multiple versions of reality, because, you know, I found myself searching for reality. What is true? You know, what is the best path forward? And the more input you've got, you're able to identify what are the most important things that, you know, you should use going forward. So it's going to vary. You know, and I would not want to specify you know, exactly what by size of practice and so forth. It depends on the personality of the practice leader, you know, the plastic surgeon responsible. So you know, it's a very flexible concept, but getting that diversity of opinion, I found, has made a tremendous you know, contribution.
Yeah, and I think you know, you bring up the good point of getting the advice and opinion of plastic surgeon colleagues who may not be in your practice. Personally, I found that very useful. I have 2 partners in my practice, but then there's probably about 10 plus other plastic surgeons around Toronto that we're talking to kind of on a weekly or every other weekly basis, just to get updated with what's going on in their practice, in their hospital, what's their feeling about how things are moving along. And I think now more than ever, it's really important that we all are working together and really focusing on the idea of recovering the aesthetic space. I think it goes a lot more beyond our personal practices right now, but actually trying to recover the aesthetic space, giving our patients, customers confidence in having aesthetic procedures and coming into our practices again. So I think it's going to be important for us to collectively do that and really try to get things back on track in whatever new normal it is.
And, one of the questions that came back, the predominant expectation is that the recovery is expected to take place in May. And I think that's a national consensus based on what I've seen. But I still can't stress enough, what can individual practices do to accelerate that? Because, when you look at this, we talked about this a little bit earlier, that, beginning to recover, beginning to initiate procedures again is not a binary event. It's not a light switch. It's going to be a ramp. And that's the way I'm looking at this. And, what we're trying to do is to help practices accelerate that ramp so that it's not just when are the procedures going to start, because we all know that a number of them are already scheduled for the next couple of weeks in April. So what can you do to accelerate that with all the challenges that are in front of us?
Yeah, I think another important concept that I've gotten from this webinar is the idea that, yeah, it's not going to be binary, right? It's going to be a gradual thing. It may vary based on the region of the country, even based on the hospital, surgery center practice. And I think Louis pointed out that we're not playing in fixed parameters right now. Things are changing so rapidly. So right now there's a concern of not enough PPE. We can't get access to certain types of tests. And that may be very different a month from now, or 3 months from now, or 6 months from now. And then a year from now, there might be other things that change the game. So I think our ability to respond very rapidly to how the parameters change is going to be really key as well.
Well, it is. And I think one point I'd add to that, and I think we touched on it a couple of times, is this concept of identifying best practices. So, getting those people around you and sharing, what defines best practices, what's working best. And, your last point is that it varies across the country. New York City is different than Salt Lake City. So, being able to adapt and be flexible in terms of what works in one region versus another, is part of the decision making. But in any event, I'm convinced that the individual practices and plastic surgeons can drive this much more effectively, intelligently than the alternative of riding the wave and resorting to the averages. So that's one of my key messages here. How can we accelerate this?
Mm-hmm.
Thank
Louis,
you, Jeff, for your comments.
Louis, any final thoughts?
Okay, but again, I think, those thoughts that we have to be flexible, and safety is above all the most important thing. And what I'm starting to notice in my office is that the patients are ready to go. They want to go. They've been cooped up. It's my staff that's really, so when we talk about PPE and setting up protocols, what I'm seeing is more concern from my staff than the patients. Some patients are even starting to get cavalier and come to the office without masks and things like that, remove their sutures and, but my staff is really concerned. So I think what Jeff says, if we can drive this and set the best policies and the protocols and all that, to make it safe, not just to demonstrate that we're safe, but to make it a safe environment for our staff. I think that's going to be a great message out there for plastic surgery.
I hate to make the comparison, but being hunkered down here in Santa Monica, or Santa Barbara actually, for the time being, there's a big difference between the precautions that you have to take between going to Whole Foods versus going into a plastic surgery practice for a procedure. And that's where discipline comes in, and you're absolutely right. Safety is first. Definition of safety is very different than it is in any other part of our life. So And that's part of the credibility and confidence that patients have in you all. And that's a standard that you have to continue to improve.
So, you know, I think a lot of us are really wondering what it's going to be like to return to practice and start providing elective surgical and non-surgical care to our patients. Louis Rios, who's in Texas, has put together a task force that's consulting with the Texas Medical Board to try to get some ideas about what this might look like. And one of the people that's on the task force is Gathe, and Bill Adams and Louis Rios were able to have a nice discussion with Joe to get some ideas of what pre-screening may look like for us. And also a lot of you have heard about the variety of tests, both in terms of antibody tests. And so I think Joe can shed some light in this discussion as well. So why don't we move to the next slide, Blaine? All right, let's play it.
Joseph Gathe Jr. I'm an infectious disease specialist in Houston, Texas, private practice for over a 30-year period of time. So I'm in the trenches, physician, taking care of patients, and spearheading one of the community efforts here in Houston to deal with the COVID-19 problems that we're having. So here's what we know and here's what we don't know. The first thing is that the COVID-19 can look like anything from an asymptomatic carrier all the way to some mild issues, all the way to a fulminant infection. And it can present anyway. It doesn't have to just present with nasal and chest symptoms. It can present with nausea, vomiting, and diarrhea. It can present with headache. It can present with fever. It can present with no fever. So it's really a clinical diagnosis. So the concern that the plastic surgery community is going to need to have is to try to figure out who actually has the disease process and who doesn't. And that's going to mean we have to look at testing protocols to figure out where people are that you're going to be coming in contact with. So here's the issue with the test as we have it, and how we're going to we're going to need to approach it in the future. The first thing, and the easiest way to give an example, let's say you get exposed to COVID-19 today. The test may take over 7 days to turn positive. The first test that turns positive is one called a PCR test. That PCR test is a nasal swab that we do looking for the virus in the cells, and we send that test off. The benefits of the test is if it's positive, that means not only it's there, but you're potentially infectious. The downside of the test is it can take over 5 days to come back, and the test is very operator dependent, meaning if the operator didn't take the specimen correctly, you will get a false negative. And in point of fact, the false negative rate is up to 40%. And so that test does not, one that is very beneficial to use practically. The second set of tests coming out are what we call more rapid tests that look for antibodies. The benefits of the rapid test is that you can get the test back in less than 15 minutes. The downside of the test is it may take 7 to 15 days for that test to turn positive once you've been exposed to the virus. And so if you got exposed yesterday, this test doesn't help you to say whether or not the process is there or not. The third problem with the test is we don't know the performance dynamics of the test. There are now over 70 companies that are looking at trying to get a test on the market. And so the tests are all over the place as far as who's doing it, who's going to have access to it, and which tests are going to come back to be ones that we could use. And so some kind of way our practices are going to have to navigate these good sides and bad sides of these tests in order to be able to get back into practice. And so we came up with what we call a hierarchy. They're class 1, class 2, and class 3 patients. Class 1 we would consider to be low-risk patients. Well, who are low-risk patients? The low-risk patients would be the ones that don't have underlying disease processes, that have done the self-quarantines that we've asked to do, that are entirely asymptomatic, and for the most part look like that they have not had any specific exposures to COVID-19. In that group of people, we felt that you could get by with doing one of the finger stick tests looking for IgG and IgM, assuming after a questionnaire they have not had any symptoms that would suggest COVID viral infection in the past couple of weeks. Our second hierarchy are a group of people that are at moderate risk for COVID-19. Who might that be? Well, the classic ones would be first responders, nurses coming in for a tummy tuck, police officers, bus drivers, grocery store attendants, people that have had to be in areas where they may have been exposed to the virus but not know that they have. These people would theoretically be asymptomatic when you would see them for their procedures that you're scheduling them for, but because of risk, there would be a little bit more of a concern that they may have been exposed to the virus at some point in time. And so our thought process in that group of people would be to do one of the finger stick tests, again, the 15-minute rapid test, but do one at time point 1 and do it one time point 10 to 14 days later, with the assumption that that test should turn positive within 10 to 14 days after exposure. The third group of people would be high-risk people that essentially you wouldn't want to operate or see in your spas at this point in time anyway. Those will be people that are sick. They have fever, they have chills, they don't feel well, they have high risk for COVID-19 exposure, and those people need to be seen by their infectious disease specialists to get them taken care of.
Okay, so Joe, so in terms of the testing, if you have somebody that's got no history, I mean, it would be kind of what you classified a low-risk patient, no exposure, no symptoms, then what is, even if that, let's just say, even if that person was exposed but didn't know about it, wasn't having any symptoms, what's the likelihood that they would be infectious?
There would be very low likelihood of being infectious, and you're doing the test partially to be 100% sure that there's nothing there, but partially also to know if they have been exposed and they're immune, their IgG is positive, then you don't have to worry about that patient in your practice for the most part from here on out. We don't know 100% that IgG protects you, but we feel fairly confident that that's going to be a pretty good marker that you're not going to be at risk for coming down with COVID-19.
Do you have any recommendations? So if there's a practice that says, I want to be able to offer one of these rapid tests, how does somebody decide which one they're going to get?
That's a very good question. The right answer right now is we don't know, because everyone is having a test that they're using and trying to figure out what's going on. I think everybody's probably heard about the Abbott test. It's been on TV and whatever else. I don't know if it's any better than any other ones that are being worked at this point in time. I think as time goes by, the test will sort of come down to a least common denominator of ones that make some sense.
We kind of made a little bit of a distinction between maybe a surgical patient versus somebody who might come into the spa. We also talked about the availability of the test, because maybe some communities aren't going to have the test, so you're not going to be able to test everybody that comes in. In addition to, there was one person that saw 200 spa patients.
Yeah, I heard that.
So it may be kind of impractical to be able to do that. So would you agree or have a comment on, it's not just going to be testing, and we can't just rely on the testing because we might not have that available, but it's going to be a combination of doing proper screening ahead of time, asking the proper questions, and then what did we kind of determine about, like, a Botox patient, for example, that walks in the door? So take that versus a surgical patient. There may be a different approach.
Right. If you're a low-risk patient and you're seeing them in the spa and you really don't have access to testing and you're comfortable with the fact that you really think they're low risk based on your questionnaire of, really no exposures, they did self-quarantining, they haven't traveled, they don't have comorbidities, you've seen this person in your practice for a while, then probably that patient can get away without testing. As we said, we're worried about the moderate risk people that may have been exposed, our first responders, our nurses, our grocery store people, whatever you want to call it, more of a moderate risk. That may be a person either in the spa that you may want to at least get a test before you see them versus as well as in surgery. And then the high risk person, it is just not going to be escaped. You're just not going to get through the questionnaire at all. They need to be seen by a healthcare professional.
And Joe, when you're doing the rapid tests, do you recommend doing one that's going to test for both IgM and IgG? Or
yes, yeah,
okay.
there's no doubt you need both. And there are kits that are coming online that have both. And I think the kits that are going to make it to the market are going to still, but because you need to know, you're going to need to know each one. If you have one or the other, it's not going to tell you what you need to know. So yes, it's better to not do any unless you're going to do both.
Okay.
So if they're IgM, they're acutely infected and you don't want them even, in your office, maybe even go to an infectious disease doctor because they're acutely infected. They may be asymptomatic at that point, but a few days later, they're going to be asymptomatic. Now, people will show a positive IgM within how many days of being infected?
It takes the median time to develop an IgM test from symptoms is about 10 days. And so we say between day 7 and day 15, you're going to see everybody that's going to respond to that, to have a positive IgM. Day 15, 99% of people are positive at that point.
And IgM clears in about 2 weeks?
It starts going down and IgG starts going up at that time. So you may have a cross where you actually see both in some people because they're crossing that threshold. But I think the important point for the team to know is if there's IgM present, that person needs to be considered infectious until proven otherwise. Correct.
All right, Joe. Well, listen, thanks so much, and really appreciate you helping us out. And hopefully someday I'll meet you in person. But
I look forward to it. Yeah, I got you. My sisters, I got 2 sisters up there, anesthesia and OB-GYN. So,
right.
So I know you guys up there. But you have my email if there's burning questions. I'll keep you as up to date as I can, especially if things change that I think make a difference to who you all are representing, and I'll keep you abreast of what I know.
All right, Joe. Thanks again.
All right, take care. You guys stay safe. Talk to you later. All right, bye-bye.
Thanks.
Well, that was great, Louis. I think Joe, summarized everything really well. Now, one of the things is this idea of the asymptomatic carrier. Louis and Joe had talked more about people with from about 7 days from the onset of symptoms that people will develop IgM. How about for the asymptomatic person? Is that, I guess, the same thing, right?
I didn't hear the last part there, Jamil.
I guess it's the same for an asymptomatic person about 7 days after exposure to COVID that they're going to develop IgM.
Right. He said it starts developing in 7 days and 90-some% will have it by 14 days.
Mm-hmm. And then really it's the patients who've had exposure and then go on to develop IgG. They're basically past the time of being, shedding virus and being infective once they've developed IgG.
Right. So at first they'll develop IgM and then they'll start developing IgG. So you could see a patient when you do the rapid test that is IgM positive and IgG negative. So they're acutely infected. Then there's going to be a time where there's an overlap where they have both IgG and IgM. In both of those circumstances, if there's any IgM, they're acutely infected, and those people need to get to an infectious disease doctor to manage them, because if they're asymptomatic right there, they in 2 or 3 days, they could start having symptoms. So, one of the issues about us doing the test, once you do the test, you're responsible for that patient. So if someone comes with an IgM positive test, you better get them over, even if they're asymptomatic, you should get them over to an infectious disease doctors because they could be symptomatic in a few days. At some point, the IgM clears and a patient could have an IgG positive test with an IgM negative, and that's the golden ticket. That's where Dr. Fauci is talking about the immunity certificate. Those are the types of people that have already gone through it. They're not acutely infected. Those are the people that are probably going to get recruited to the front lines of treating COVID patients. Those are the types of patients that if you do a rapid test, you can feel pretty safe that you can do the surgical procedures or the med spa procedures, and they're not going to infect your staff, and your staff's not going to infect them. Mm-hmm. That makes sense?
Yeah, and then so you guys have developed a class, 1, 2, 3. 3 effectively we're not taking care of anyways in our practices because they have symptoms of acute illness. But the 2 was people that would have a higher risk for exposure to COVID. So frontline workers, people in stores. And so the recommendation for 2 was to do the IgM IgG test but also to do the RNA test?
No, really, he felt that it was impractical for us to be employing the PCR nasal swab for two reasons. One, it's a 40% false negative because the person who does it needs to do a good job doing it. The second reason is when you do that test, the patients cough. If you do it properly, they're coughing all over the place. So there's no way you're going to do that in your office. I even called up Quest Lab and another lab, CPL. They're not doing those tests. Those are getting sent to doctors' offices to do them. So you got a combination of a lot of bad factors that they're 40% negative. You got a bad testing environment where it's going to take up PPE. It also costs probably about $250. Medicare won't cover it unless a patient's symptomatic and they've had a negative flu test. So that's going to be a $250 test, and the results come back in a few days. So it's not going to be a real practical test in our offices.
Mm-hmm. Now, you guys highlighted again the importance of screening questionnaire, which essentially I think many of us would have done that prior to COVID, particularly with patients having treatments to ensure that they don't have any type of acute infection. One of the things that Joe had talked about also was the idea of, saying that, if they've done their quarantine, if they haven't had travel, but fast forward 3 months from now, when conceivably we're still in a similar situation with no vaccination, no treatment, for the problem, but people are not quarantined, or less people are quarantined, and then potentially there's more not only interstate but international travel. Are we potentially at a point where we're going to be asking patients to self-quarantine prior to their surgery?
That might be a good idea. I think it'll be one of like those instructions that we give. But I think if you're looking at a few months down the line, and when we have this classification system, we're saying like class 1 or low risk, in 6 weeks or 3 months, everyone's probably going to be in class 2, moderate risk, because you've gone to restaurants, you've probably been exposed. But at the same time, we might have more testing available at that time. So we might be able to employ testing a little bit more. So that could help us with our screening processes. And I think the main thing to just consider here when we're talking like to the Texas Medical Board and all that, it's a combination, and you got to think of this as like being a doctor again, right? You're just not going to look at the MRI and say, okay, the MRI says you need knee surgery. You're going to examine the patient. So it's going to have to be a combination questionnaire. Let's talk about temperature real quick. Temperature greater than 100.4, that's what the CDC is recommending. Okay, and then your questionnaires and kind of putting them all together. But I think in that scenario in the future, we're probably going to have the antibody test more available, and hopefully we will. And then we'll be able to employ that at the, right when we really need to start employing it. And then, so all these like protocols or ideas that we're talking about, we need to keep them very flexible, because right now, rapid testing may not be available, but right now may be the safest time as well, because people have been quarantined, right? So in addition to that, we need to take into account PPEs. So I heard a Houston Methodist Hospital only has 2 weeks of PPEs. And if we get back to operating again, they're probably not going to be letting cosmetic surgery go there. But if you're in your office and you have 2 months supply, well, obviously you can do your cosmetic surgery there. So it's going to be a combination of looking at, what testing is available, doing your screening, looking at your PPE supplies, which, do you have the N95s for your nurse injectors who are going to be injecting lips and the patients don't have masks on? Are you going to have tests available? So it's going to be a combination of putting everything together and making good clinical decisions like we were trained as doctors, not just looking at a test or not looking just at one piece. You got to put it all together to make good policies and have a safe practice.
Yeah, I think that's a really important thing, is that we do have to take all of this information and combine it all to make the best decision. And I think it would be naive for anyone to think that there's going to be a test that comes out that's 100%, clears them of any decision making, right? None of these antibody tests, number one, are 100%. And number two is that there's still little windows where someone can fall between having symptoms or having a positive test or a negative test, right?
Yeah, there's really not going to be a safe test you can do in your office that's going to catch them right there, because that PCR it still takes maybe at the best 1 or 2 days to get results, but then you're really not going to do that in the office. And so I think, we just got to stay flexible. We got to realize that this is a moving target. The ideas and stuff we have today and recommendations we have today may not even be good for next week, so we just got to keep that in mind. So I think, like, from our point of view in Texas, our recommendations are going to be very flexible. We're not going to, because we know certain cities don't have access to tests. So we're going to have to just do best practices with what's available as far as screening questionnaires, temperature taking, what tests are available, and then what PPE is available. I think you put that all together just like a clinician, and you can probably have a very safe environment in your office.
Yeah, I think that's important. Blaine just had a survey of when the participants think they'll be returning to providing elective services, and the vast majority, almost 80%, felt sometime in May. About 19% were sometime in June, and then you had 3% sometime in April, and then 1% kind of even further down. But I think it's, we had a discussion before this webinar, but it's so important to understand that the United States is a vast country. There's a lot of different things that go on regionally. The impact of COVID-19 has been in some places really minimal, way less than people were anticipating, and other places about as bad as it could be. And I don't think necessarily that everyone is going to go back online at the same time. I suspect, based on how badly the healthcare system locally was affected, and this may even be down to the hospital level also, not just in a city, but certain hospitals may have been impacted more than other hospitals in terms of having infrastructure, resources, supplies to allow people to go back to providing elective care. Wouldn't you agree with that, Louis?
Yeah, that's what we heard from the Texas Medical Board president yesterday, that when we were asking him about elective procedures, he kind of said, we're going to kind of punt that ball over to let each individual facility make a decision and take that into account. They need to take the PPE into account, the testing and all that. Because, like I said, Houston Methodist, for example, only has 2 weeks of PPE. In my office surgery center, and I don't want to let all of Texas know this, but I probably have 2 or 3 months worth of PPE that I've stored up over the years. So I think everyone's going to be different. And I think that in the academic settings, if there are members that are doing aesthetic surgery in the academic settings, or maybe in some ASCs, they may be shut down a little bit longer.
Mm-hmm, mm-hmm. And I think when you look at how this all unfolded, I mean, on the front end of this, a month ago, or not even a month ago, it was really top down. You saw at a federal level, there were statements made and restrictions, travel, elective surgery. But on the back end, I think it's going to happen the other way, that it's going to be much more dictated locally, because people have been affected so diversely. And I think there was some comments in the chat asking if the Aesthetic Society is going to have guidelines of who to operate on, what kind of surgery, what age. Bill, what are your thoughts on that, since you're involved in the executive, the board of directors?
I think the society will definitely have some guidelines for the membership, but I don't think the society is going to define for the membership what they should do. And I think that will be, as mentioned, governed by the state boards. The one thing that came out in that poll about medical screening, I thought was quite interesting, because it looks like 80% of people don't have a set medical screening policy in their office. And I think that's probably the most important thing you can do. I think when you talk to Dr. Gathe, he was very clear that although there's these antibody tests and those may be helpful, that is not your first line. Your first line is going to be the questionnaire and the screening of the patients, because that's going to probably do the lion's share of the kind of weed out process of anybody that you wouldn't want to be treating. So I think the society on the resource page, I think that would be one good thing, Jamil and Louis, that we can do, is put on the resource page maybe some suggested screening questions. And the only thing I would add to that is my experience is that your staff obviously is going to start that screening process, but you have to help them, or have to have a point when they need to kick it to you, because they just don't have, a lot of the people don't have the, the historical knowledge to kind of ask the right question when it gets to a certain point. So maybe once the red flag's identified, it gets sent to you, and then you can do the final screening on that patient.
Mm-hmm. Yeah, you know, it's interesting, right? We in elective surgery, we all typically do pregnancy tests, right? Do you guys do them? Bill, Louis in Texas, right?
That's right.
And I'm sure anyone that's done a lot of surgery has probably had a negative pregnancy test, but then found out a month after surgery their patient was pregnant. So at some point, I think we have to just recognize that there is some fallibility in the testing. There's nothing that's going to be binary that says you're 100% good to go. This idea of being a great historian and then combining some other investigations with it to give us more certainty that we're good to go is similar in concept to what we do already for many other things.
It'd probably be good too, on that same note, as when you guys make your protocols, is to be a little bit more conservative. So while the average patient with COVID-19 had a temperature above 100.4 on the survey to the patient, you don't want to ask that. You want to ask if they've had a temperature above 99 or 100, right? I know that we're getting to minutia there, but you know, there's an ability for patients to misdirect their answers to based on not knowing or just wanting surgery so bad. So it'll be important to account for that.
And Louis, do you want to kind of just review briefly what Dr. Gathe said about the length of surgery and things? I think we're getting some questions on the chat about what cases, you know, people would consider doing. Do you want to address that for people?
Right. So, and this was interesting because we had our Texas Medical Board president's an anesthesiologist, and he and he's with 1,000 anesthesiologists. So their groups come up with recommendations, and it was interesting because the second paragraph talked about that China paper. I think that we've all heard, and you know, it was 34 patients, and a lot of those were probably like ASA4 patients. They had surgery on their chest. And then they were letting, and they were in Wuhan, so they were letting, you know, family members in the ICU afterwards, and they had a 20% mortality rate. So there's this rumor and myth going around plastic surgery that, oh my God, when we start, we shouldn't do, you know, the 65-year-old person with the facelift, and oh, don't combine a tummy tuck with a, you know, with a breast augmentation because maybe it has something to do with surface area and then cytokines and then inflammation. And there's no way you can extract that from that paper. And that's really the only data we've had out there. But basically, if you think about it, the first week or so is maybe when you want to do the facelift patients, because that's when everybody's been quarantined and everybody's probably in a safer position, you know. And so we just don't have the data for that. And his idea was, if you've done good screening, if you've had some, you know, ability to do a test, there's no reason to delay doing, you know, a multi-procedure just based on that one paper. He doesn't see any data, and he's on chat groups and, you know, infectious disease doctors. There is no data that says like doing a tummy tuck and a breast augmentation is dangerous and exposes them to a higher mortality rate. His idea was, is if you did good screening, you're very confident in your screening, you're better off to use that extra 2 hours or so during that time to do the surgery while you've had good screening, because they can go home and in the meantime, they can get infected with COVID. Or just the idea of having to have another general anesthesia and the risk for that, him being an infectious disease doctor and not even a surgeon, thought that was not a good idea. So I think these ideas we need to kind of dispel. Bill, I think you kind of came up with some interesting data yesterday you might want to share, and you're looking at writing a paper about your surgery center that stayed open and was doing like ASA 1 and 3 urgent cases. Maybe you want to share that, because I think that data is better than that Chinese paper.
Yeah, well, that all came out of there's a paper, just briefly, because I know we need to get to Jeff Nugent's presentation, but it was a very poor paper out of China that showed a very high morbidity and a high mortality in patients that are having a so-called elective surgery. Now, these were cases, things like esophageal resections and renal cancer resections, so certainly not typically what we're considering to be elective surgery. But the place I operate actually has been open for urgent cases, so it's mainly like orthopedic procedures, locked knees, other things that are deemed more urgent. And so we've tabulated that data, and from the 6-week period, March 1st to April 15th, there's 302 cases. There are no no morbidities, basically. No patient was hospitalized after. There's certainly no mortality. No staff contracted COVID. So we're going to publish that just to have some, more representative elective cases in the literature.
Well, I think we're going to shift gears and talk a little bit about our meeting that's coming up on Saturday, April 25th. As most of you have probably heard by now, Bill and I and our education team and the Aesthetic Society have been working really hard in the background to be able to bring plastic surgeons and particularly our Aesthetic Society members some great education. I know that a lot of you plan on coming to the meeting every year and plan on getting 25 to 30 hours of CME, and certainly the cancellation of the meeting has been a big impact for people, although it's probably not the first thing on anyone's mind right now. As we get a few months into the future, we'll start to think of all the regular responsibilities we have. So I would encourage you all to check this out. There's been some emails that have gone out about the Aesthetic Meeting 2020 at home. The registration site is up now, so if you go to the Aesthetic Society website and click on medical professionals, you'll get right to the meeting. And essentially on Saturday, we're going to have a morning and an afternoon session, so 2 3-hour courses, and there's going to be 2 tracks. So you can sign up for a morning course and an afternoon course. Now, if you're interested in seeing the other course that was on at the same time, everything will be recorded and available on demand after the 25th. In addition to that, we're going to have 16 on-demand instructional courses. And so you'll have a total of 37 hours of CME that you can claim. If you can't be with us on Saturday, April 25th, you can still work through all of these courses over the next several months to get all of your CME. So it's going to be really exciting. The courses we have are going to be on buttock augmentation, facial rejuvenation surgery, aesthetic breast reconstruction, and then body contouring after massive weight loss. So it's going to be a fantastic program. We have an amazing platform, so it should run very smooth. So I'd encourage you all to sign up and join us on the 25th. And if you're unavailable that day, I'd also encourage you to engage the on-demand programming as well. Now, I think the other thing that's really important to note is on the 25th, we have an 1.5-hour lunch break where we'll have a way to virtually interact with our industry partners and exhibitors. And there's going to be some different sessions with them. So I would encourage you all to engage with industry as well, who's helping to support the meeting and support our education. All right.
That was a good one. Let me actually shamelessly plug that we will be there. Sientra will be there present at that meeting, as well as many other vendors. And we'd love to have your attention during that 1.5 hours to reintroduce our leadership team and our products to you if you're interested in breast surgery in the next couple of months. So thanks for having us on, Dr. Ahmad and Dr. Adams.
Yeah, thanks so much, Blaine. Bill, do you have any last comments?
No, only that next Thursday, that's 2 days before the online meeting. And I think it's still a little up in the air whether we're going to have another webinar or we're just going to go on with this meeting. So just stay tuned. We will send out a blast to membership to confirm one way or another. But take it from here, Jamil. Great job.
All right, everybody. It was great spending Thursday afternoon with you all, and be safe. And hopefully we're going to get back on track soon, and hopefully we've weathered the worst of the storm. We'll see you guys all at the latest on Saturday, April 25th during the Aesthetic Meeting 2020 at home.
Thanks, Jamil.
Thank you, guys. Be well.
Bye.